ADHD is one of the most misdiagnosed conditions in psychiatry, and most people don't realize why. Let's break this down the way you actually need to think about it clinically. ADHD is a neurodevelopmental disorder, which means it doesn't start in adulthood. Symptoms must be present before the age of 12, even if the diagnosis is made later in life. So, the first question you should always ask is: has this been a lifelong situation? Always ask this question if teachers or family members have made comments about their focus, attention, and or hyperactivity in their childhood. Or did it just start recently? If symptoms started in adulthood, you need to pause because that is not ADHD until proven otherwise. Now, diagnosis is not just about symptoms. It requires persistent inattention and or hyperactivity presence in two or more settings. And most importantly, functional impairment. This is where people get it wrong. Struggling to focus is not enough. There must be real life consequences in the area of their academic, occupation, or relational. Now, this is the part that separates a careful clinician from others. You must rule out conditions that mimic ADHD because anxiety causes poor concentration, depression causes low motivation, PTSD causes hypervigilance and distractibility, sleep disorders impair cognition, and substance use affect executive functioning. If you don't rule this out, you are not diagnosing ADHD, you are mislabeling symptoms. And this is an important clinical pearl I will need you to take note of. ADHD attention is interest based, not importance based. That is why patients can focus for hours on something engaging but struggle with basic tasks. That is not inconsistency, that is dopamine dysregulation. If you are diagnosing ADHD, this is the level of thinking required. Please follow for more clinical breakdown on ADHD. Take care.